Professor Dr. Paulo Jorge Ferreira.
Muito boa tarde. Good afternoon, everybody. We are here because of neurodegenerative diseases, and we are also here because of the Lídio Pinho Foundation. So I'll be mentioning some of the issues related to the former, and then a short word about the latter. Neurodegenerative diseases, I'm not an expert on them, of course, but they sound as a sort of a broad term, an umbrella term for a range of diseases. And they have different expressions, some of them pertaining to movement, and some of them pertaining to mental function, cognitive function, and memory. This second group is called dementia, as far as I know. And dementias are responsible for many neurodegenerative diseases. Among this set of dementias, we have Alzheimer, and Alzheimer is accountable for many of the dementias. And this is the situation right now, as we speak. Since age is a risk factor, and our society is getting older by a combination of factors, the two most important of which are the fact that less and less children are being born in many countries, and that lifespans are getting extended due to better health care. So I'm really afraid that in the future, Alzheimer, from explaining a great deal of neurodegenerative diseases, may in fact explain a large percentage of health issues in the world. So whatever we can do here and now to prevent and to advance the state of the art concerning Alzheimer and neurodegenerative diseases in general will affect future generations in a great deal, promoting the quality of life, promoting better health care, reduced expense in health care, which is important because it frees money for other diseases as well. So I'm very happy that university, together with the Lídio Pinho Foundation, is pursuing these topics, and I leave here a strong thank you for doing this. Also, I wish to thank the chair professors, Jens Wildfang and Philippe Pierre, who is not here, I suppose, for leading and helping us towards this effort. Wherever we do here in the present will affect, I repeat, the future. So I look forward to this discussion as something very fruitful. I encourage all of you to proceed and go on and contribute to a better knowledge of these diseases. By doing that, we'll be serving the future. Thank you.
Convidamos agora a senhora diretora do Departamento de Ciências Médicas, professora doutora Odete da Cruz e Silva, a tomar a palavra.
Hello, good afternoon. I would like to welcome everyone. My best regards to our rector, Professor Paulo Jorge, our vice rector, Professor Artur Silva, all the university, academy, and all our guests. Thank you very much for joining us this afternoon. I start with a question, which I myself will answer. Do you know how many people are affected by Alzheimer's disease? In Europe, we're talking about 10 million individuals. In Portugal itself, we're talking about 200,000 people that are affected by this condition. And the number is likely to be over 300,000 in the next 7 years or so. We are faced with a challenge, an enormous challenge. How can we accurately diagnose Alzheimer's disease? Because Alzheimer's disease, in its earliest phase, it's not so easy to diagnose. Cases of depression and other conditions can give the same clinical evidences, the same signs as Alzheimer's disease. So later on, it's easier, of course, to diagnose. but in the early stages it is not so easy. There are excellent techniques based on imaging, and just to touch a tiny bit on the science, when we talk about Alzheimer's disease, we are talking about two types of protein aggregates that stick together like glue, and one type will stick and deposit outside the neurons that are the cells in the brain, and once these deposits happen, the cells can no longer talk to each other. So therefore we have problems recalling memories and so on. And then there's another type of deposit that occurs in the neuron itself, that we like to call neurofibrillary tangles, but at the end of the day you have two different types of deposits, and they destroy the structure of the brain and the communication from cell to cell. Imaging techniques that are used and effectively used as diagnostics can readily identify these aggregates. It's an expensive procedure, and we don't have so many of these equipments, so it's not so easy and it's not so accessible to everyone. The next gold standard, if you like, is to do a lumbar puncture and or a spinal puncture to make it more accessible, where you collect the liquor, and you can, these proteins that are deposited in the brain, you can detect the changes. Again, this technique gives you excellent results, but it is difficult to do a lumbar puncture. So the ideal would be from a simple drop of blood, and you know how easy it is to collect a drop of blood, to be able to diagnose Alzheimer's disease. So this is the holy grail that everybody is after. And we were able, in Aveiro, I don't mind my glasses, I'll pick them on the way up. And in Aveiro, we were able to join in this challenge. And we were able to do this because of the funding, as you have already heard, from the Cátedra Ilídio. The foundation supports two chairs, as you already heard from our rector, and one of them is in the area of neuroscience. So who better to tell you about our contributions in this area than the scientist himself, the doctor, whom I will introduce next. And this, in fact, opened the possibility for us to work on several fronts. Not only were we able to test techniques developed in Germany, in Portugal, we were able to provide this test, this diagnosis, to patients in Portugal. The funding, as you've heard, is from the Cátedra Ilídio, but we also had support from FCT, and we also had support from the American Alzheimer's Association. So this, in fact, was networking from different funds. Professor Jens Wildfang himself is the director of the University Hospital in Göttingen, and he's also head of the Department of Psychiatry and Psychotherapy. He has extensive experience in this area. He has held chairs in Essen, Erlangen, and now in Göttingen. He is a leading scientist in this area. He has optimized methods for testing for special Alzheimer's biomarkers in blood, and he's known worldwide, has hundreds of publications, and it is a pleasure and an honor to receive Professor Jens Wildfang today. And I would like, just before I hand over the microphone, I would like to personally, and also as head of the department, to thank the Foundation Ilídio Pinho and engineer Ilídio Pinho, because he has, in fact, been fundamental in helping us with this network and with bringing international know-how to Aveiro. Thank you.
Prosseguimos a sessão e chamamos a palco o Sr. Diretor da Clínica de Psiquiatria e Psicoterapia do Centro Médico Universitário de Göttingen, Professor Dr. Jens Wildfang.
So, need some time to get fixed. Yes, I really appreciate to present our novel data referring to a blood assay, so blood-based diagnostics of Alzheimer's dementia, and I hope that I can demonstrate in the next minutes that this is actually possible. So coming from CSF, coming from imaging, PET imaging, positron emission tomography imaging like glucose PET or amyloid PET, which is excellent, but PET is extremely expensive, €2,000 PET, or cerebrospinal fluid, spinal tap is not minimal invasive, so it's painful, it's not minimal invasive. We are really, I think it's a really achievement and a step forward that it seems to be possible in blood. Now, within the Auditório share, we follow several axes of research, like fundamental research, training of students. So for the last years, we had always co-workers of your side in my lab, like Tanya, like Barbara Mugado, who is presently staying in Göttingen. And we focus on translational research. And within translational research, this talk is dedicated to predictive dementia diagnostic based on blood biomarkers. So the issue is blood-based early and differential diagnosis, so to not only diagnose Alzheimer's dementia, but to differentiate Alzheimer's dementia from other dementias. This seems also to be possible. And to demonstrate that this may be an attractive perspective for dementia prevention. The talk will focus on a beta peptide-based blood assays because, as Odette detailed, the extracellular plaques in the brain are constituted of aggregated beta peptides, and phosphotau-based blood assays, tau epitopes are present or are constituents of the neurofibrillary tangles within the neurons. And again, those two protagonists are the most promising biomarkers in blood. Since 2017, there has been a rapid development of blood-based dementia diagnostics for AD. And meanwhile, it is clear that even a preclinical Alzheimer's diagnosis, so identifying patient at risk for Alzheimer's dementia by blood-based assays, can be realized. And as I will demonstrate in my last slides, even a differential diagnosis, blood-based differential diagnosis, so differentiating the dementias seems to be possible. And we think that this technology will enter clinical routine diagnostics within approximately 2 years. But as always in science, new technologies also impose new risks and drawbacks. And one drawback may be because of the high market potential that the market will be flooded by assays which have not been validated adequately. So we observed this in CSF-based, cerebrospinal fluid-based diagnostics, which is part of international guidelines now, that initially assays were promoted who were not validated adequately. What is the added values? What are the perspectives? There's a high potential for the optimized development of preventive non-pharmacological preventive interventions. The preventive intervention, however, should start before the molecular pathophysiology has reached the complete neocortex. Unfortunately, this is the case when Alzheimer's dementia is diagnosed for the first time clinically. Then the whole neocortex is affected by the new pathology, unfortunately. Accordingly, successful preventive intervention should start preclinically, as early as possible. However, this is per definition, because it's pre-clinically. You cannot diagnose this with clinical tools because it's preclinical. This calls for biomarker-guided diagnosis of preclinical ED. Now, stepping into the details. The decreased ratio of the two A-beta peptides, A-beta 42 and A-beta 40, is the best validated A-beta peptide blood biomarker of Alzheimer's dementia. Meanwhile, our group has developed an A-beta peptide assay which does combine an initial immunoprecipitation, first step, with commercially available high throughput capable immunoassay technology as a second readout step, thus avoiding mass spectrometry. Because this is usually not used as high throughput assay in clinical routine neurochemistry. We have all the equipment of mass spectrometry at site in Göttingen because a cross-bridging share with Max Planck is part of my department, so we have everything necessary to do extended mass spectrometry, but this has no potential for clinical routine labs. It's much too expensive and you need full academic persons to run it. So it wouldn't have any market potential. A further automation of the method is promising to offer cost-effective, high-throughput analysis of blood samples in routine clinical chemistry labs. Now, how does it work? The first step is enrichment of A-beta peptides from human EDTA blood plasma. Immunoprecipitation is performed with functionalized magnetic beads decorated with an antibody against the amino terminal of A-beta peptides. Then we developed a novel elution technology which is directly compatible with second-step immunoassays. So after this elution method, we don't have to remove any constituents or further treat the samples because this would significantly increase the bias, so increase the coefficient of variation. We just need to cool down the sample and then it can directly enter the second-step immunoassay platforms. And here we use multiplex immunoassay sandwich platforms like Mesoscale, it's established in our lab, or other A-beta immunoassay platforms technology. So we have an ongoing joint research initiative with Roche Diagnostics, which is submitted for publication, and most importantly, the CMOA digital ELISA platform, where you can measure in the actually femtogram range per mil those peptides. And actually, now we focus on the CMOA technology. We have a brand new HDX equipment established, which arrived 2 weeks ago, and this is really promising technologies. Now, first step, automated robotic immunoprecipitation. There we have a cooperation with a company, RoboScreen, who offers the SciBio Felix. And one example, because you have to know the effect size, so the drop of the ratio 42 to 40 in blood in ED is only roughly 17%, so below 20% lower as compared to controls. So a really tiny minute derangement, but as you know from diabetes testing, HB1AC, if you have 6%, it's fine. If you have 9%, it's clearly pathological. So some parameters are controlled in a really narrow range. But as a consequence, if you come up with an assay which has a coefficient of variation of, let's say, 15% or 12%, you are lost in noise. So only highly accurate assays can work and reveal this difference, diagnostic, meaningful difference of, let's say, 17%. And this is the reason why you need highly precise, best case scenario robotic automatic platforms. Now, this is an example. Here we tested 80 patients, 40 patients with Alzheimer's and 40 patients, 40 control patients. The diagnosis was cross-validated by CSF biomarkers and or AMNOT PET, so that we could really be sure, or that we could rely that this is really an Alzheimer patient, not only clinically, but cross-validated by gold standard biomarkers, so cerebrospinal fluid biomarkers or AMNOT PET imaging. And in the controls, it was really important to rule out the subclinical trait of Alzheimer's disease. Because unfortunately, everybody of us who will have the luck to become 90 years or older does have a risk of 30% to develop dementia. And every second dementia is Alzheimer's dementia. So all of us who will get 90 years or older have a risk of 15% to develop Alzheimer's dementia. That's fact worldwide. Now, the problem is that the pathophysiology of Alzheimer's dementia starts almost 20 years preclinically. So if you want to rule out this 15% may be hidden in the controls, you not only have to take care that they have no clinical evidence of Alzheimer's dementia, but they also have no evidence of the hidden subclinical molecular trait of Alzheimer's dementia, because you would have a bias of 15%. So also the controls were investigated by CSF and or AMNOT PET to rule out in the controls the trait of Alzheimer's disease. And then we studied this highly, deeply phenotyped cohort by this robotic IP, followed by immunoassay quantification, in this case on the mesoscale platform. And not shown here, all single measurement were below lower level of quantification. And then the receiver operating curve characteristics, the area under the curve, to differentiate between both groups was 0.85 and 0.86 in the next independent trial. And we could realize a coefficient or variance of only 5%, with one outlier below 10%. So this is really important that this is a precise methodology, otherwise you are lost. Now this is an example, not published, but a co-worker of mine, Jonathan Vogelsang, now at the time staying at Harvard Medical School as a clinical scientist for some time, but he is about to publish this and to write the paper. So this is a multi-center Delcode cohort. So we have in Germany the institution of the so-called DZNE, the new German Centers for Neurodegenerative Research, with one satellite in Göttingen, but they are distributed all over Germany. And within this consortium of top neurodegenerative disease researching sites, we set up this Delcode multi-center cohort, more than 1,000 patients. And they are enriched in patients with preclinical Alzheimer's dementia. So patients which were investigated by cerebrospinal fluid blood biomarkers or AMNOT PET, glucose PET. And in this cohort, 60% of the patients were in these preclinical stages. And in a subcohort of 375 patients, we had these CSF biomarker patterns, the signatures available. So we did know if somebody came to the clinic with memory complaints, but still driving his car, doing his job, so in a preclinical stage, just annoyed by the memory complaints, but no evidence for Alzheimer's dementia, so the everyday life performance was not significantly impaired, but some diluted symptoms, memory complaints. And now, if this patient comes with a Alzheimer prototypic signature in cerebrospinal fluid, then this is mild cognitive impairment due to Alzheimer's disease. And even one step before, you have only subjective memory complaints. So if you come from a high level, like an academic person with a good memory. This is the whole story. The whole disaster starts with memory complaints which cannot be actually diagnosed by simple psychometric screens because you come from a too high level. Unfortunately, at some stage, you may reach then later the level of Alzheimer's dementia. And again, then you can differentiate subjective cognitive memory complainer due to Alzheimer's disease or to depression. This would be reversible or other cases. So 60% of these more than 1,000 patients were in the clinical stage, in the preclinical stage of Alzheimer's dementia. And now, if you look at the analysis in the blood, we could realize a diagnostic accuracy of 81% with a sensitivity. This is really important for a blood assay because this is a screen assay to identify a potential patient at risk. The specificity doesn't need to be too high because if this patient gets a red flag or a yellow flag, then of course you will validate this by additional measurements. So the screening sensitivity is important, those 86%. So the decreased ratio in blood, 42 to 40, stratified by the ApoE4 genotypes. Is there ApoE4 LL4 or not? It did realize this sensitivity. Now, together with Roche Diagnostics, this is submitted for publication a few weeks ago. You could even realize a diagnostic accuracy close to 90%. But this was an MSD readout. Now, the second protagonist, these are phosphotau epitopes and phosphotau-based assays. This has only become feasible because nowadays, for several years, we have novel ultra-sensitive immunoassays like the digital assay, the CIMOA assay, which can measure in the sub-picogram range per mil, to measure the phosphorylated tau epitopes in blood plasma. Currently, the most promising epitopes are phosphotau 181 and phosphotau 217, and our, I think, top candidate would be phosphotau 231. Now, the good feature with the phosphotaus is that they're elevated and the effect size is higher. So I told you the decrease of the ratio 42 to 40 is only 70%, so that's not too much. So the increase of plasma epitopes is more stable and more prominent. It's 1.5 to 3.4. Effect size is significantly higher. And most importantly, as we could demonstrate this for the A-beta peptide ratio not shown here, it correlates nicely with the CSF gold standard signature. With armlet PET, I didn't, due to time restrictions, I didn't show the data here. But also, this elevations of plasma tau epitopes shows a really excellent close correlation with the gold standard biomarkers of Alzheimer's dementia, of course, most pronounced with tau PET, which is now available for several years, 3 to 4 years. Now here, it's a little bit overcrowded, the slide, but I will guide you through the slide. On the left side, A, you see these, the measurements, in this case of phosphotau 217 in the Swedish biofinder cohort, is like our DEL-code cohort, also a multi-center cohort. And what I just want to indicate, in the lower part, you have new degenerative diseases like Parkinson, or new degenerative dementias like Parkinson dementia, or PSP or whatever, who may pose, especially in the initial phases, for the neurologist, for the clinician, differential diagnostic problems. It's not so trivial to, if everything starts, to separate everything. And what you can nicely see, that you have a clear elevation of phosphotau 217 in MCI, for example, due to Alzheimer's dementia, so mild cognitive impairment, MCI, with a prototypic Alzheimer pattern in CSF or positive amyloid PET. So MCI not due to old age depression, where this is also possible, it would be reversible, no problem, or other causes, but mild cognitive impairment due to Alzheimer dementia. And there you can see a clear elevation, highest elevations, of course, in clinically overt Alzheimer's dementia, but interestingly, in other neurodegenerative diseases or other neurodegenerative diseases like Parkinson or Parkinson dementia, there are no significant elevations, for example, also in pure vascular dementia. It's very important, if you diagnose a vascular dementia, that you have something like CSF or amyloid PET, because the vascular damaged lesions you clearly see in MRI imaging, but the hidden concomitant Alzheimer's disease as a mixed dementia you wouldn't see. So you can only diagnose a really vascular, pure vascular dementia by the combination of both methods. Of course, the Swedish Codex did know this and did do it, so these are really pure vascular dementia. And in really pure vascular dementia, there was no significant elevation of phospho-tau in blood. Now, on the right side, you see the receiver operating curve characteristics for phospho-tau 217 in blood. This is a very upper curve. It's B, in slide diagram B, compared to other biomarkers in blood, like neurofilament, light change, and others. And you see the really outperforming diagnostic feature of phospho-tau 217. Now, on the lower right-hand side of the slide, now you see the really hot finding. So here, phospho-tau 217 in blood is compared to the CSF biomarkers, like CSF phospho-tau epitopes in cerebrospinal fluid, or even imaging like tau PET or amyloid PET. And you see that's more or less the same. There's no significant difference anymore. But a tau PET costs €2,000, amyloid PET costs €2,000 per scan. CSF is not minimally invasive, so this is really surprising and amazing. Summary and perspective. Composite blood plasma assays combining their beta-peptide ratio 42:40, stratified for ApoE epsilon 4, because you gain in diagnostic performance if you stratify for the presence, yes or no, plus phospho-tau epitopes. Our most promising candidates are phospho-tau 181 and 231. 217 is excellent, but it's on a very low level. In some controls, you can't measure anything, and that's for clinical chemistry, that's not so nice. In phospho-tau 231, it has, in absolute terms, higher levels, so you can measure the reference values, mean plus minus standard deviation in the controls. And as a clinical chemist, I'm not, but colleagues from clinical chemistry don't rely if you argue, yes, it's nothing measurable in controls because the brain is fine. They say, okay, that's your hope, but I want to see the numbers, the measurements. So phospho-tau 231 you can measure in every single control. You get a mean, a standard deviation, so this is more promising. And these composite blood assays are promising to offer diagnostic accuracies exceeding 80%. I would say you can realize at least 86% seems feasible for preclinical AD. 10, 15 years before the dementia comes. Perspective, the combination of composite blood plasma assays is cognitive screening tests, which the technician can do at the side of the GP with some training. A study nurse can do it. That's not a problem, because the time of the GP itself is much too precious. He cannot do it himself. But it's not necessary. It can be done by a student or a study nurse with appropriate training. Will offer a novel, cost-effective, and minimal invasive tool for the GP to identify patients at risk for Alzheimer's dementia roughly 10 to 15 years before the dementia comes. So time enough to offer preventive interventions. Patient at risk for ED, identified by the strategy, can be offered optimized treatments to reduce known AD risk factors. This is diabetes mellitus, a strong risk factor. It doesn't induce AD, but if you have, in addition, diabetes type 2, for example, your deterioration is much faster. So you can slow down the deterioration of Alzheimer's dementia if you adequately treat diabetes mellitus type 2. Also, arterial hypertension, adipositas, social isolation, and depression, and underestimated by a lot of colleagues, also our side, but there was an excellent paper in Lancet Neurology, hearing loss. Very important. And at the other side, strengthen protective interventions like diet, exercise, cognitive stimulation. Moreover, a first causative disease-modifying drug therapy now has been approved by the FDA. This is the antibody aducanumab. We will see it removes actually quantitatively the plaques. The 10 milligram dosage per kilogram body weight after 1 year washes out all the plaques. But we don't want to have molecular cosmetics. We want to see clinical improvement. And so the colleagues from Europe, from the EMA, were not so convinced with the data available so far that this is so clearly correlated to clinical improvement that they would give the approval for Europe. The USA colleagues were much more convinced, so it's proved in the US, and we will see the Europeans say, okay, in this case, the colleagues from USA are faster. We will just wait 1 year, 2 years, look at the data from the US, because they have a post-marketing study they have to do in the US. The FDA said, okay, it's really promising, but we want to see the post-approval, so a post-approval study, which is ongoing. And the colleagues in Europe say, okay, we are conservative, we just wait 2 years. Yeah. But it's promising. And there are other antibodies from Eli Lilly, donanemab, and others, gantenerumab from Roche, which may be even better. So something is now moving. And this would offer really a causative therapy. But of course, you should start this therapy before the molecular avalanche has reached the whole neocortex. Then it's more or less too late. So in preclinical stages. Now, to come back to the share, the Eli Lupino share, this share does enable or enabled use methodologies developed at our site and to apply this to the proteges population, test new biomarkers for Alzheimer's disease developed in Göttingen and test them here. The internationalization of the Eli Lupino Foundation in supporting of neurosciences, training young researchers in the area of neuroscience and signaling. And I think, here's the XY, I think it's 55 for that. We checked it, yes, 55 publications. So in the few years we are working, we actually achieved 55 publications, partly in high-ranking journals, which refer to the foundation. Now, future perspectives. I think it would be a really interesting and promising to establish at site a national reference lab for preclinical neurochemical research, maybe serving the northern part of Portugal. Regional, national, and European priorities to address dementia and aging populations could be worked at. Adopting preventive strategies and healthy lifestyles, so lifestyle changes. A priority in the Portuguese health ministry, especially if you look at diabetes, type 2, and Alzheimer's dementia. Supporting ongoing preclinical research lines at UA and UMG. Exploitation of previous investments made in the UA, namely that of Eli Lupino catheter. Mission statement of this lab: contribute to the development of preclinical biomarker research, preventive health-related strategies offered to high-risk cohorts, which will be identified by predictive dementia diagnostics, maybe plus psychometric screens. novel therapeutic strategies, especially, and I did not detail this, including drug repurposing. So we have excellent ideas in the lab in transgenic mice models with cannabidiol, and we will start a study on this because cannabidiol, which has which does not cause any addiction, so it's not equivalent to tetrahydrocannabidiol. So completely different story. Cannabidiol has no addictive side effects, and it clearly suppresses inflammation. There are studies in rheumatoid arthritis, and we clearly observed that it depresses glial neuroinflammation, obviously mediated by the CB cannabidiol receptor number 2, which is overexpressed in activated neuroglia. So we developed a ligand, isotope-labeled ligand for this receptor, which will be checked if this can be used in nuclear medicine and PET as imaging of microglial neuroinflammation. And we want to investigate if this compound, which really removes quantitatively in the animal models of mice, quantitatively removes the plaques, if this may be useful in humans. And we will make a proof of concept study where we will perform one armlet PET, apply the compound, have another armlet PET 1 year later. This you can do in a small cohort of 30 patients. It's powered enough, but it's only a proof of a mechanism study. It doesn't tell you anything if there may be any clinical efficacy. But first we want to show if the mechanism which works in the transgenic AD models, the mice models, does it work in humans? This is drug repurposing. And there are other examples that you may apply a drug which is safe and prescribed for completely different indication. There are studies going on from compounds from oncology. There's a brand new study referring to a compound which is used to treat multiple sclerosis, also attacking or addressing glial neuroinflammation. So you could also apply those patients identified with a high risk, those more or less safe drug repurposing, or offering a drug where you know the safety profile because it has been administered 100,000-fold worldwide to other patients. So this is drug repurposing. Contribute to healthier societies and, of course, attractive for student and clinical training and mobility. Now, what would be the costs? Automatic robotic immunoprecipitation. This is the first analytical step I introduced, for example, with the SciBioPhaedics. Second step, multiplex immunoassays you need, like the MSD platform. There's a brand new novel S-plex technology which can also measure, like Simoa, in the sub-picogram range. We have MSD established, or the Simoa platform technology, which we may prefer. Barbara Mogado from your side is working just now in Göttingen with the Simoa technology because we were trained to generate our own homebrew assays. This is really attractive because you at your side you can develop monoclonals. So if you can work with your own monoclonals against phospho-tau, against the beta-peptides, and integrate these monoclonals into the assay cost, you have really low costs. Yes, so it's really attractive. If you then offer this assay to GPs and samples which come in, you can make some earns where you can co-finance maybe other research. So it's important that the Simoa platform offers an excellent possibility to generate homebrew assays which you generate yourself. This is also possible with MSD, but a little bit more complex. So we estimate assay cost for duplex measurement of a sample €75, and you would need approximately €500,000 for this one-time investment for the instrumentation. Thank you. So I think we have the discussion as a part of the roundtable.
Segue-se agora momento musical.
And just before we start, a few words. When we're talking about Alzheimer's disease, music is particularly relevant. It has been shown that music can be of benefit to Alzheimer's patients. So it's not just the musical moment, but it's of relevance when we consider Alzheimer's disease. In fact, it has been shown that the memories that are most preserved are those memories pertaining to music. So it is a way to reach those patients through music. Not only the patients, but also the caregivers. It has been shown that it can reduce anxiety, it can reduce stress. So it's perhaps not surprising that Professor Jens Wildfang is also a composer. And we have the privilege of having two musical moments. The first one will be a piece proposed by Jens Wildfang, and it will be played by Shusher Hoveyan. And just a few words. I had the pleasure to meet Shusher yesterday, and it is an honor to present her here today. Shusher was born in Armenia. She was born into a family of artists, and at the age of 5, she was playing the piano. At 6, she had the first solo. She has played throughout the world with many concerts in Armenia, France, Ukraine, and Germany, of course, and very recently in Spain. She has been recognized by all her talents, and she is at the moment working at Hanover, where she is undergoing postgraduate studies in music, of course. So it is a great pleasure for us to welcome Shusher, and she has a long history with Portuguese music, and she knows Dulce Pontes very well, and she can sing all the words to Dulce Pontes. So she's very pleased to be here in Portugal, and we are very pleased to receive her. So Shusher, thank you very much for coming to Aveiro.
Após este momento musical, retomamos a sessão. Chamamos ao palco, como moderadores, o presidente da direção do Egas Muniz Health Alliance, professor Dr. Artur Silva. E como participantes, a diretora do Departamento de Ciências Médicas, professora doutora Odete da Cruz e Silva. O diretor da Clínica de Psiquiatria e Psicoterapia do Centro Médico Universitário de Göttingen, professor Dr. Jens Wildfang. O coordenador da consulta de memória no Centro Hospitalar de Entre Douro e Voga, professor Dr. Luís Ruano. E a neurologista no Centro Hospitalar Vila Nova de Gaia Espinho, doutora Mariana Branco, para falarem sobre as novas metodologias para diagnosticar a doença de Alzheimer a partir do sangue.
Boas tardes, good afternoon. After this excellent presentation from Jens, I have the hard work to provoke these colleagues that are experts on the subject. I'm only an agitator of this round table. And after listening to you, the first question that I think that all of us are asking is, why to do diagnosis of a disease without cure?
It's me.
Yes.
Yes. Yes. Because cure is an option of cure is emerging, and even with non-pharmacological interventions, you can slow down the acuity of the deterioration. The problem is that there's a lack of studies in the past who focused on non-pharmacological interventions, but there are studies out, the Finger study and others, the study of Dubois in France, where he could nicely show, if you look at those patients in this age society who were amyloid positive, that they actually showed a highly significant slowing down of their speed of deterioration by lifestyle modifications. And then you could argue, yes, but that's so simple. If all of us would do this, so it's good for all of us. Why do we need the diagnostics? Yes, but because at least we are lazy persons. So I also enjoy to sitting on the sofa or playing the piano instead of doing sports, enjoying a really good glass of excellent Portuguese red wine. But if I would know that I'm at risk, my motivation to change my lifestyle would be much, much higher. So this is lifestyle modification. And then there's very good evidence that drug repurposing, that there may be drugs already on the market for other indications, maybe also used for AD. And now, very recently, we have promising monoclonals who clearly lower beta peptides. This is without any debate. Nobody questions this. But who may have a chance not only lower their beta peptides, remove the plaques from the brain, but that this may be correlated to slowing down of the disease acuity. But there's clear evidence that you can only profit significantly from this preventive intervention if this starts early. If you diagnose AD with clinical tools like in our memory clinics, and I did this years as a medical doctor, so I had a training in neurology, a specialist in neurology, and then in psychiatry. Even if you're really experienced, if you diagnose it for the first time, the complete neocortex is reached by the neuropathology. And we would like to start when it originates from the entorhinal cortex, from a very tiny area, and then it explodes and reaches the whole cortex. So that we should start much, much, much earlier.
well, it's good that it's my provocation starts to be fun. So now I'm well, going to our colleagues from neurology that are in the hospitals, and what you think that this tool can help us, you, in the normal life that you receive the normal people arriving at the hospitals with different different stages of the illness. How this can help us, or how this can can help you to organize the life of these patients that arrive to the hospitals. Luis or Mariana?
It can help us a lot, actually, especially now that new therapies are arriving, or so we expect, because as Professor Odette said, in order to make the diagnosis, you have to perform a lumbar puncture, which is a very invasive, painful, time-consuming, and also space-consuming exam, because we have to have a space in the hospital to perform it, and there are so many patients, we don't have that resources. In the moment that we have the therapies, we will have to perform the diagnosis in order to treat the patients. We will have to know for sure if they have Alzheimer's, or if they don't have dementia, or if they have other dementia. And so it is very useful to have an exam, an effective exam at a lower cost, easier to perform, because it will really be a need, truly a need.
Yeah, if I may add something, even now patients come to us and say, I have memory complaints, I need help. And some of these patients have depression. Some of these patients have vascular dementia, and we can help those patients. We can help patients with depression, we can help patients with vascular dementia prevent additional damage. And if we can know for sure that they don't have Alzheimer, we can give them a much more precise message in the ways to improve their well-being. And it also helps us to predict what will happen to the patients. Although we cannot treat most dementias, if we have a precise diagnosis, we can communicate with the caregivers and tell them what to expect. And this is really important for the families and for their social support, knowing that this type of dementia, you can expect that in 1 or 2 years you will be bedridden, and you have to prepare for that. Or let's invest, you will stay functional for longer, so we can try therapies to make him functional for a lot of time, where to invest, because people don't know and they come us with questions, and these tests will help us answer those questions.
Jens said also something about this, the lifestyle that the people has. It's if you know the answer, perhaps you can also orient the people in terms of the lifestyle that they have. By sure, yeah. That this, I know that all of you were involved in this project, but from the academia, that we are more devoted to identify the biomarkers and markers. How it is, of course, that Jens have already said something to us, but how difficult it is, or how in which stage it's the demonstration of this, and in terms of equipment, we have already all the equipment, and so you can say something about this.
There are the technical limitations, because the biomarkers are more dilute. So these methods have been finely tuned, much through the collaboration with Jens and the Cátedra Lídio. And then there's the practical side. How do you measure the technology? How do you measure? And so far we have been able to measure samples from Portuguese patients, but our limitation right now is that we are sending the samples to Germany. So the techniques are not difficult. They are fairly easy to set up. And I should also acknowledge the work of Ana Gabriela Henriques, that we've had people from her group and from my group going over to Germany. So we have the scientific know-how. The techniques they stand up. All that science in the middle was just to show this is a really good test. It's as good as the lumbar puncture. And so we are confident. So we are in a phase that if we can now set up a lab, we can start within the academic center, offer this to the hospitals. And we have 2 representatives here. So it's nice that they are critical of what we are doing, and they can tell us how best we can adopt things to be of service. So we really are in a unique position in Portugal. From a technology standpoint, this is not happening in Portugal. So Aveiro could have a first mover's advantage. There is some investment, and I think, we're all willing to, go after that and try and have a reference center here. I should also add that in Aveiro, when there's a quality control for the CSF diagnostics, and in Aveiro, through a European project of Jens, Aveiro was one of the first groups to enter in the quality control. And this is run by the American Alzheimer's Association in a Swedish group. And in Aveiro, we are number 13 in this quality control. So we were right there from the beginning when they were doing the quality control for the CSF diagnostics. We did not keep it up because of all these problems. You need the patients, you need the lumbar puncture. But we are very well positioned in this network to now do the same for blood. But we need the hospitals with us, we need the academic center with us, and obviously aspects like the Cátedra Lidiopine just give us that final push that is so important.
Yeah, it's nice that you refer the clinical academic center, because we are together. So the hospitals, you had 2 representatives, and one is in the other side of the road, and ourselves. And Jens, you referred 500K for the equipment.
Yeah.
Of course, but this is an equipment that can serve for the region of Aveiro, or a big region, or let's say the central region of Portugal, or if we think in the clinical, can be a smaller equipment?
No, because our technology is high throughput capable. That's the reason. The second reason why we choose this robotic immunoprecipitation. Actually, the 2 other leading groups, that's this Bateman from the US and Nakamura, there's a Nobel Prize winning group for mass spectrometry behind this, and Shimatsu, they followed the same strategy we applied. First, extract the beta-peptides from blood to get rid of the thousands of high abundant other proteins which do an epitope masking. And this was really important. And then we have a little pre-concentration, but that's not so critical. The removal of the other interfering proteins was really helpful. And then we have more or less on a golden tablet the eluted, really pure and nice buffer. So it's a golden tablet for the second step immunoassays. And so this robotic first step and the multiplex second step, both are high throughput capable. You can also run them on the 365 well plate format, not only 96. So that's not a problem. So one set would be sufficient.
Yeah, so we need to fund the money for the clinic,
and
clinic
then
academic
and
center,
maybe,
and then we serve all the hospitals. Yeah.
And maybe in issues of return of investment, it's important that, of course, these equipment, especially the CMOA, is also really, really attractive for completely other research. So cell culture, supernatings, completely different issues, not related to ED, because you can set up your homebrew assays. And Barbara Mogado from your side, yes, she is part of our team now with a PhD grant for 3 years. And we had a co-worker, Dr. Hadeland is her name, from Simoa, who spent 3 days at our site, and then you get all the technology and the know-how to develop home assays, and you can do it in everything. So, for example, if you then generate your own antibodies and don't have to buy in the antibodies from a vendor, but you have your own antibodies, and your cost for the assays are quite minimal. And then you have a really significant return of investment. So the return of investment is I think, is there within short time. Yeah. So this is one important reason why we, I guess, will focus on the Simoa. MSD is also nice. They have an ultra new S-Plex technology, which is as sensitive as Simoa. Now, for a few weeks, was released. But it's much more complicated to set up the homebrew assays. So to summarize this, 2 issues. The platform can be as well as used for completely different research. And I think you can get a return of investment simply by the patient samples coming in.
Excellent. I'm going once again to the neurologists, but now thinking, well, as we know that lifespan is increasing, that refer the number of the people suffering from AD in Europe, but if we think in the world, it's more complicated. How do you treat these patients? How do you follow the disease? Because I think that perhaps the first ones that come to you, it's only some loss of memories or something, but then when the plaques start to be increasing, it's complicated. And which is the effect of the disease for the normal life of the people?
I think in my head, I divide these patients into 2 groups. The ones with the initial forms, in which you have to explain the patients and the families that they have a disease, a neurodegenerative disease, what it is, what will happen if they want to know it, because that is a question also, if they want to know it. This phase is a more sensitive one, and there is not much to treat, because we have some treatments that can maybe for some months the patient will perform better in terms of memory, but there are not many medications for this. And then we have moderate to severe forms of the disease, in that the families already know the disease, the patient knows or doesn't know anymore because it's so severe, the dementia, that the patient don't know, but what he needs is what the patient needs is more like measures like helping the feeding, the hygiene, the aggression. Maybe some patients get aggressive, and we have to medicate to the aggression, to the apathy, to the insomnia. So I divide the patients, the management of the patients, into these 2 groups nowadays with the tools that we have nowadays.
Our main goal is really to make the families and the patients' life the better we can, because these patients have a huge burden on their relatives and other caregivers, and we can make all the difference in the world if we can alleviate some of this burden. If we treat these patients right, we are able to prevent sometimes caregivers from unemploying themselves just to take care of the patients, because we can help them to prevent all the issues that can happen. We try to educate the people and to make them accept that this is a long goodbye, and when they are prepared for this, the journey is easier.
Yeah, because I think at least some of us has already faced this type of diseases. In my case, it was my parents-in-law, and both, as Mariana said, one it was aggressive, one it was very, very quiet. So it's different aspects, and the consequences that it's for the normal life and for the life that those that take care of the people. Yeah. It's very complicated. And that from our side, so we have this let's say this assay that we can implement. We of course that Jens says 75. This is for Germany, perhaps in Portugal we can have some less. I'm joking. So, and
but excuse me. CSF diagnostics is much more expensive also, because theoretically, we as a trained clinicians, we could theoretically exclude indications by investigation of the eye, but nobody of the three of us would rely on this to exclude some brain tumor where this would have serious complications if you draw the, so you always need imaging. So we will not perform any CSF TAP in my clinics not having neuroimaging before, because you may be sued for 100,000 € if the patient dies. Yet that you do a spinal tap in patients where you should never have done it. So to be honest, the CSF you need also to test for this neuroimaging. And then the biomarkers in the CSF are even more expensive, and it's time consuming. Yeah, you have to exclude coagulation problems. So if the patient has an increased risk of bleeding, you are not allowed to do this. Some patients are on Macoma, etc. So it's quite a story.
But well, that. Imagine that the assay it's already done, it's okay, implemented, and how, in terms of the academia, how we can continue to support this type of research. It's only after, if you have already established the assay, it's only epidemiological studies that we can do to try to see which this population and so, or what do you think that we can still working on the project?
Yeah. There's a lot to be done, because in Jens' presentation, he spoke about 2 biomarkers only. He spoke about A beta, and those are the plaques that form outside the neuron. So if you look at the aggregates outside the neuron, that's A beta. And then I said there were those other aggregates that we call neurofibrillary tangles. That's that protein tau. So Jens only spoke, and when I say only, it's a lot, only spoke about 2 biomarkers. But the ideal, and we've spoken about this in other projects, is that through a drop of blood, not only do you diagnose Alzheimer's, but you can do a patient profile. And if you can now, through that single drop, do a patient profile, and this is our ideal, maybe we'll get there before we retire. It would be to have a plate where you profile not these 2 biomarkers, but others. Yeah. And you can see, okay, this patient does not have Alzheimer's, but has Parkinson's disease, or doesn't have either, and we had a very interesting case with schizophrenia that looked a little bit like Alzheimer's, and this was a study in Sweden. So just by 1 drop, you could ideally profile all this. And then you can say, okay, you have genetics. And genetics is important because genetics gives you a basal risk. The ApoE, that's a gene. And if you have one type of expression of that gene, the E4 type, you're more likely. If you have another one, you're protected. People do not study this. Are you protected? Are your genes protecting you for Alzheimer's? Because the same gene, if it's one type, it's risk. If it's another type, you're protected. And there is a lot to be done if we could profile. So yes, genetics is important and 100% behind it, but just because you have the gene does not mean that all the proteins will be expressed, because then other things happen. So the ideal situation would be 1 drop of blood, profile the patient, and you have an idea for other dementias, other neurological disorders. So in terms of research, there is a lot to be done.
Yeah, for example, neurofilament light chain. The colleagues will know if you have patients with multiple sclerosis, for example. This is a pure neural damage marker. There are two things to it. It's really unspecific. It increases in blood for dozens of etiologies, but it's very specific for the brain. If you do a soccer training, what is Kopfball? If you train Kopfball, yes, sir. If you do this, let's say, for 10 minutes and measure then a neurofilament light chain, it's increased. So really, really sensitive. And in multiple sclerosis, or in amyotrophic lateral sclerosis, for example, as MS or ALS, you have significant elevations. So then there's a new parameter, GFAP,
Yes.
which is a perfect readout for astroglial activation, which is even much better than measuring GFP and CSF. So the blood is much closer in this case because astrocytes are part of the blood-brain barrier with their end foots. So yes, there are a lot of other intriguing biomarkers. Then there's this brand new O-link technology where you detect a target, an antigen, a protein, only if 2 antibodies bind at the same time to the protein. And each antibody has a DNA link. The DNA forms a bridge, and you do a PCR amplification. And this allows you to measure more than 3,000 proteins down to the level of NFL, down to the level of 30 picograms per mil in blood plasma. So, and what we are now about to do, to create composite scores from microRNAs. So this is another story. MicroRNAs control the expression of a protein network, you know, and proteins identified by the O-link technology. And then you may actually come up with signature, blood signature, composite blood biomarker signatures, maybe with 3 to 4 microRNAs and 3 to 4 proteins for different diseases. So there's a big perspective in this area. And actually, when I was working at Max Planck, after my studies, I stayed 4 years at Max Planck Institute doing basic science, protein biochemistry. My dream was actually, could it be sometime be possible that the blood may become a window to the brain? And now it happened because we rely on engineers on physics. Because this developed the ultrasensitive assays which now allow us to reach this detection sensitivity, that we can measure those highly diluted proteins, which was not possible before. No? But now it's possible to use the blood as a window to the brain, not only in the negative axis, so damage, deterioration, but also the opposite. So if you induce by certain antidepressants, by psychotherapy, synaptoneogenesis, neurogenesis, if you measure BDNF, etc., maybe we can also more or less improve psychotherapies by just trial and error looking which intervention is more increasing this synaptotrophic factors in blood. Yes, and then we should make it for this. So it's a complete new area in research, in neurology, and this is only due to these novel technologies.
Now I'm looking to the colleagues. Someone wants to make some questions, some remarks? Don't be shy. João, microphone there.
So good afternoon. It was very interesting talk, and so the topic is also excellent. And but my question is, I work in PET, so this is my main question. So about the PET also gives functionality, and at the same time, this provide the mapping of this functionality. How this can help in the diagnostic, and how can also helps in see the future of the disease.
Yeah, so did I understand you right? You were referring to PET diagnostics?
Exactly.
So positron emission tomography. Yes. Yeah. Shall I answer, or you want?
From the PET brain scans for Alzheimer's disease are really expensive. So the logistics of it are also really difficult. So honestly, I think that the future, it will not be possible to treat the number of patients that we need to treat if we have to rely on PET scans to diagnose. So I don't, this could be wrong, but I don't see really a future for PET scans in the clinical practice in this field, as the numbers are so huge that I don't think they can be a reliable, a valid tool for widespread usage in this field, because as soon as we're starting to have these alternatives that are really reliable, and this, when we have these tools, knowledge can move much faster, because even for studying diseases and make discoveries, we'll be able to include much more patients, and our epidemiological, I'm an epidemiologist, and our epidemiological studies, our clinical studies will be much more cheaper. So I think, and I might be wrong, that this will become the standard, and we'll move away from PET. This is my opinion. I could be wrong. But,
yeah, I agree. I use PET nowadays more for frontotemporal dementia and primary progressive aphasias because we don't have biomarkers, blood or CSF reliable biomarkers, and it is useful to evaluate the pattern of hypoperfusion in order to perform the differential diagnosis, but not in the suspicion of Alzheimer's disease, or in a patient who has prominent memory complaints.
Yeah, I'm a little biased in this area because my wife is a medical doctor and she is doing nuclear medicine. So she's an expert in PET and all this, you know. And so I have to be always careful what I say.
If not at home, you will have problems.
Yes, but I perfectly agree. So PET for screening is much too expensive. But what I predict is we have a PET established in Göttingen, so AMNET PET and now Tau PET. What I would predict is that AMNET PET is substituted by blood ratio 42:40. Because on AMNET PET, you only have more or less information, plug yes or plug no. If you look at subregions, you don't get significant added information. And the decrease of the ratio 42:40 with AMNET PET is so excellent that this yes-no information, this nominal information, comes also in by the blood assay. And then something very attractive emerges. This is a combination of glucose PET with the measurement of the ratio in blood. Because then you have some evidence of this trait, molecular trait of Alzheimer's coming from blood, phospho-tau in blood, and then you can exploit all the differential diagnostic potential of glucose PET, as my colleague focused, for example, frontotemporal dementia, progressive, the progressive aphasias, like the semantic form, the aggrammatical form, and the logopenic subtype, which belongs to AD, then the hybrid or mixed phenotype of ALS and FTD. 20% of ALS have FTD, and 20% of FTD have, unfortunately, ALS. That's a catastrophe for clinicians also to be confronted with these patients because you are more or less helpless. And in all this differential diagnosis of the new entity, FTLD, frontotemporal lobar degenerations, where all these belong to, and the atypical Parkinson syndromes like PST, PSP, their glucose PET is much, much more helpful. And if you then combine glucose PET, which is not so expensive, it's maybe 70 euro, 700 euro, but not 2,000 euro, with this blood biomarkers, we see a big future in this combination.
Thank you. Some more questions? Yes, here, please.
Hello, thank you very much for your presentation. I was wondering, given your results regarding sensitivity and specificity, if in clinical practice this could be used as a first screening of patients, and for instance, in patients with early onset Alzheimer's disease, because it only affects 5% of patients, but still, in cases where there is a family history, could you use this type of screening to rule out if that person might be developing Alzheimer's as well or not? And could you see this being used for screening of treatment like aducanumab? Because I'm aware that it was recently approved. And how do you see, and when do you see it applied to clinical practice? Do you think it will be long till we have this kind of diagnosis? Or it's something that we look forward in the next few years, as kind of speaking?
I also have that curiosity, honestly, because I don't know. I'm hopeful that we will be using this blood biomarkers soon, but I don't know if we will be using, like in 2 years, as a general screening or as a selective tool in order to decide this patient will be treated, this one will not. And I'm also very curious about it, and we have the expectation that we can use it soon to help us to choose who to treat, because we won't be able to treat every Alzheimer patient. But I don't know if there is an answer already.
Yeah, I see it the same way. I think so. Within 2 years, they will enter routine diagnostics. But even in CSF diagnostics, which is now part of all the international guidelines, it's recommended. The NICE criteria, the German criteria, the US, it's in all these S3 guidelines, it's recommended. But it took several years to actually get to know the pros and cons. So just entering that the first assays have approval for in vitro diagnostic does not mean that you know how to work in clinical terms with this tool. You get to learn to work, the pros and cons. So this will take several years. I agree. But it is useful, for example, the three of us know that even with a lot of experience in memory complainers, for example, if a patient comes with old age depression and memory complaints, the complaints could be 100% just due to the depression. Because even a young student like you or a postdoc with depression has significant cognitive complaints. Sometimes it's a tragic that as medical students is then admitted to my hospital because the first evidence of his depression was a suicide attempt. Because he was such powerful, sportive, everything like this, highly intelligent, and always worked, if I power myself, I will solve everything. But if you have a depression, you can try to empower yourself as much, it doesn't work. So this student, female student, male student is completely frustrated, tries a suicide attempt, and then we diagnose what you have as a depression. And then you have a significant cognitive impairments. But if you treat depression successfully, everything is fine again. So the differential diagnosis in many patients is this pure first episode late onset depression, for example, or is this a combination of neurodegenerative disease plus depression? And now we know for several years, due to the Harvard aging study and the Sao Paulo brain bank, because in Brazil the opposite is true. You have to do an autopsy if you have any minor question of the diagnosis. You're first to do it. So these brain banks were much more population representative than the European brain banks. And then all of a sudden the colleagues realized, look, there's a subphenotype of Alzheimer's dementia where your first symptoms of the dementia is an organic depression. How does it come? It's very simple. Because in the subphenotype of the patient, 30%, unfortunately, the new pathological avalanche hits those brain structures first who are responsible to control affective states, like the amygdala, the locus coeruleus, the dorsal raphe nucleus, and then, of course, then the first symptom of your dementia is depression. And in the textbook, when we do our exams in medicine, we learn one of the risk factors for Alzheimer's dementia is depression. That's, excuse me, bullshit. Because if you exclude from these calculations the first episode late onset depression, so a lot of stressors with 30 years, divorce, whatever, no depression. Now 67, and everything is fine. And now a depression comes. Why? And in my clinics, I always ask in the morning conference, if a new patient comes in, let's say 67 years, 65 years with depression, is this a first episode, late onset depression, or is this a new episode of a known depression? And if it is a first episode, late onset depression, you have a risk of 30% that it is, let's call it, Alzheimer's depression. So, but if you now have the blood assays and nuclear medicine tools, you can do diagnostics. You can see, yes, of course, it's depression, but in addition, it's a hidden trait of forthcoming Alzheimer's dementia. Now, in those patients, you would do the following. Of course, treat the depression. A post-stroke depression you can treat with antidepressants. The antidepressants are working horses. They don't care. If this is depression due to psychological stressors or stroke, they work. So they work, we know, also in new degeneration plus depression. They work. But in this case, you would offer, in addition, a disease-modifying anti-dementia therapy. Now imagine if aducanumab or something would come. Then you would like to offer such patient both. So there's a lot of options emerging. And referring to your question, target engagement or monitoring and treatment, yes, for example, NFL. There are nice data that if such an antibody or intervention is effective, then if you measure every 6 months, you clearly see that the increase of neurofilament light chain as a readout of proximal of neural damage is flattened. So, for example, if you would treat a patient in a personalized precision medicine, and if you don't see any positive effect on the long term on repetitive NFL or GFAP measurements, you would question, this may not be a responder. So there are a lot of perspectives for clinical routine handling of patients.
Yes, which?
Just to comment on this question of depression and Alzheimer's disease, I completely agree with Professor Jans. This is reverse causality, but this has been a matter of discussions for decades now. And if able to do a cohort study using these biomarkers in the blood, we would be able to answer this question much faster than. And like this, there are several questions in this field, several epidemiological and clinical questions that we can start to unravel as soon as we can get access to it. And also coming back to neurofilament light chain is an example in multiple sclerosis. It's a marker of disease activity and disease severity. And we have, in a position for Alzheimer's disease, we have a lot of treatments. And I also have work in the MS clinic. And this will be a really, really helpful tool to identify patients that need to get more intensive treatment. And the whole field is really excited about this. And as soon as we can able to perform neurofilaments in the clinical practice, it will be performed, I think, in...
Yeah, and maybe a tandem assay, not only measuring with a reference that the patient is, the baseline is her or his reference, but not only measuring relative NFL, but also GFAP.
Yeah,
would be for
GFAP,
you very interesting, the astroglial activation.
Yeah.
And then you may see that this patient would need this combination therapy, and then there's a significant drop. So yes, you can, you would use this blood base, where you can do repetitive measurements, these if you can't do this, theoretically, but it's not done. But you can have high frequent serial measurements and maybe fine tune trial and error, maybe the combination anti-inflammatory therapy.
Yeah. And so I think this opens a whole new field for neurology, because in most organs we have this kind of measurements, we have this kind of biomarkers in the blood, and it makes it really easy to make clinical decisions. It makes it really easy to develop new treatments, to answer epidemiological questions, and we are now approaching this era, and this is really exciting. And I think this will be of great clinical use throughout not only research centers but clinical practice. Even I think some of these tests will go to the level of the GP in 1 or 2 decades.
Something else? Well, I'm going in another direction. They referred a little bit. It's how we can correlate the Alzheimer's disease with the other comorbidities. It's the Alzheimer's disease, the consequence, or it's a cause? For the practice, what do you feel, Mariana?
Well,
I'm a provocative.
Alzheimer's disease specifically, or dementia?
Dementia, neuropathological diseases.
Dementia is not a primary disease itself. It is a symptom of a whole spectrum of diseases. We could give a class here talking about it. I don't want that. In terms of Alzheimer, we know that it has several comorbidities associated. The personality changes, the problems that lead to respiratory problems.
But I was thinking in some like diabetes, other...
Yeah, in terms of that, we know that diabetes and other vascular risk factors can contribute to the development of Alzheimer's disease. Alzheimer's does not cause that comorbidities, but they are associated because vascular risk factors contribute to the development of Alzheimer's disease. But Alzheimer's disease have other comorbidities that we could think that it have nothing to do with Alzheimer's. And I was talking about respiratory problems, urinary tract infections, like a sort of comorbidities that are associated.
And Luis, and what about sports and food?
Sports?
Yes.
We know there's a disease that it has long been described in people who do boxing from repeated head trauma, and it its neuropathological bases are not completely clarified. Some of those patients seem to develop a secondary Alzheimer's disease kind pathology. Others seem to develop another different kind of brain pathology. It's not completely clarified, but what we know for sure is that it puts them at risk for neurodegenerative disorders. And we are now seeing that this happens even in sports with less contact. American football is completely clarified for now, and there's data from European football,
Yes,
from our football, and from other contact sports, and we're still trying to get a grasp in why some of these athletes go on to develop this disorder. In American football, it has become, there's a correlation between the player's position on the field and the number of impacts they go on to suffer throughout their career, but this is not explaining everything. For our football, it's not so clear now. We know there's an increased risk, but we're still trying to determine the factors. American football, for a long time, they have very good data on contact because they collect all this kind of statistical data for the sport. And only in the recent years, we have been collecting this data for football. I think we might be able to have an answer in the future. What we do know is that non-competitive sports decrease the risk of dementia. So, as a public health message, we don't have to be concerned with this effect because this only seems to be present in competitive sports, not just professional, even amateur, but competitive. Okay, like Sunday leagues or something are also at risk, but non-competitive sports are exempted from this. Regarding food, it's really hard to measure the contribution of nutrition to developing chronic disorders. But there are some hints, but they are really only hints and hypotheses. We don't have a compelling evidence of super nutrients that could help us prevent dementia. We know that the main driver of cognitive impairment risk is overweight and excessive consumption of any kind of food that increases our risk for overweight. Much more than this, it's more speculation than, and we would like to indulge in speculation, but we don't have so many data to prove it. And there is some data that omega-3 and fatty acid oils could prevent Alzheimer's disease and other neurodegenerative disorders, but not really as supplements. The clinical trials have been negative, but there is some ecological data that populations that consume these kinds of foods have a lower risk, but we're not sure.
Menanda, you refer that we can continue to do sports.
Yeah.
Yes.
Can I think what Dr. Luis Rondo is saying is absolutely true. We need to do more research, and we follow 600 patients in the Aveiro region, and we are finding some correlations between cognitive performance, I would not say Alzheimer's disease with the data that we have, but cognitive performance and diabetes. And we found this before, it was spoken about a lot, a link between gastrointestinal disorders and cognitive diseases. And everyone's talking about the gut-brain axis. So we really need to do more research. And just to give you a little flavor here, for example, that bad guy, the A-beta, it is degraded in our bodies. Normally we degrade it, so it doesn't always end up forming these aggregates. But curiously, the enzyme that degrades that A-beta is the same enzyme that degrades insulin. And if the enzyme has to choose insulin or A-beta, it will degrade insulin. So clearly, we have a lot more research to do in that area to understand these subgroups, these stratifications of Alzheimer's disease, because it's I think Alzheimer's disease will be many diseases, just like cancer, it's many
like
diseases.
schizophrenia. There's
Yeah.
not schizophrenia, but 5
There will be
subtypes.
many Alzheimer's diseases, and we really do need to invest a little bit more in this research and look at the clinical backgrounds.
I think another really interesting feature related to what the colleague told is the integrity of the blood-brain barrier. So if you look at the blast trauma in the Iraq war, where the soldiers, even from the US side, were too close to these bombs who worked just with a blast trauma. Okay. So they had some damage, vibration damage to your head, to the head, and boxing. It's a nice example. And others. And unfortunately, now we see, and this was my experience because now I do my job for almost 30 years now. So what I observed when I established one of the first in Germany, this CSF-based dementia diagnostics, that those patients in the preclinical stages, but with the trait, the signature of ED and CSF, where we know unfortunately they would become in the next years AD, if they undergo a big operation like TAP, so with intubation and narcotics, that there may be a problem that those narcotics, like isoflurane narcotics, which physiologically then induced by anesthesiological, opens the blood-brain barrier, allow certain factors, complement factors from blood, assess the brain, and they may be seed for seed education, that you activate the silent bomb. And so everything, so now this is the reason why we undergo now in Germany, we initiated this for the time being only in Göttingen, but we want to apply this multi-center study that we want to investigate if those patients who come to our hospital and who have to undergo a surgery with intubation and narcotics, if those patients who come with a hidden trait of a hidden molecular trait of Alzheimer's disease in their blood, are those patients significantly threatened by increased risk of developing dementia after silent interval of almost 6 months. This is a delayed post-OP deterioration. This is a novel known problem in medicine. And unfortunately, we have clear evidence that this is the case. If this is true, then in a multi-center study, this is powered enough to analyze what is it. Is this the time of brain ischemia? If you have a big operation where you have an extracorporeal circulation, you maybe have a prolonged hypoxemia to the brain. Is this the narcotic you use, isoflurane, for example? What is it? But if we could identify this, then we could have a specialized SOP. If a patient comes in, you would perform the blood test, reveal the risk with ApoE and the blood biomarkers. Simple, easy, not costly. Does he come with a hidden trait of Alzheimer's disease? If yes, you would use a modified SOP for the surgical intervention. So, and a lot of things point that if the blood-brain barrier is deranged and some bad guys, bad proteins from the blood come over to the brain, like C1q attack factor and others, then the whole problem starts.
Yes, here, please.
Thank you. So considering what we were talking about, the blood-brain barrier, so things coming in, and also talking earlier about the lifestyle, I was wondering, how about the clearance mechanisms, things like the lymphatic system and the clearance that happens during sleep? How is that factoring in?
Yeah, sleep is very important. The colleague also mentioned insomnia. So my training was by a professor, Professor Rüther, where I did get my clinical training to become a specialist for neurology and psychiatry. His kind of hobby was sleep research. And he was one of the leading sleep researchers in Germany. Now he's retired. And at those days, we thought sleep is important for consolidation of memory and so on, and psychotherapy. But now, last 5 years, a very simple concept becomes really attractive. The brain is the most active organ of our body with the highest metabolic rate. It's not the liver, it's the brain. And so a lot of intermediate metabolism molecules are generated which are potentially neurotoxic. So also the brain needs a kind of lymphatic system to kick them out. And the CSF is not enough. And the colleagues will know this. There's a system which has been identified in the early 1920 years, the G lymphatic system. So the astrocytes are very important in this story. And now, if the G lymphatic system is active to remove all these intermediates, potentially neurotoxic intermediates of brain metabolism, the interstitium is changing. In animals, you can quantify by almost 60%. So you can imagine that this is not compatible with what we do now. Listen to music, be concentrated. Yeah? So you may need sleep, and especially non-REM, slow-wave sleep, that this stupid clearance function of the brain can be active. It's not compatible with cognitive, highly concentrated work. So one very important issue and function of sleep may be just to have a kind of renal function of the brain to get rid of these bad guys. And there's evidence, unfortunately, that conditions which impair specifically the slow wave, non-REM, non-rapid eye movement, so where you do not dream, the focus, the majority where you do your dreaming when you sleep is in the REM, rapid eye movement sleep. But this is a non-rapid eye movement, slow wave periods of the sleep. There the G lymphatic system is active, and in animals now with radioactively labeled peptides, there's clear evidence that also beta peptides are kicked out of the brain by the G lymphatic system. Now imagine due to depression, repetitive depression, or primary insomnia. Primary insomnia is identified as a new risk factor for Alzheimer's dementia years ago, and the colleagues said, why this? Now we have evidence why. And now some companies really have identified this maybe as a new treatment option. Could we develop drugs who maybe activate the G lymphatic system to remove these toxins? Yeah. So this is really, really interesting.
Well, we are almost finishing, so I will go in another direction. It's, well, when we know each other for more than 10 years,
yeah.
discussing a little bit about the plaques and how we can aggregate or disaggregate the plaques from the beta, and because a lot of it is known and a lot of discussion is about this. So if it is better to try to avoid the aggregation, to form the plaques, or if we have the plaques, if you can have a medicine that treat and deaggregate, destroy the plaques. But then there is the other aspect that perhaps the fragments is more toxic than the plaques itself.
Yeah.
How we can play with this? And I will start with this.
It's true what you say, that as you try to destroy the plaques, they can become more aggressive, and rather than making the situation better, you make the situation worse. So undeniably, the best thing is to prevent the formation of the aggregates. And that just gives us more of a reason to have an early diagnostics. So if you can prevent the plaque formation, you are much better. And for this, you should, obviously, genetics can be a part. So a good, ideal diagnostic should also consider that aspect. So undeniably, avoid the plaques. A healthy lifestyle, just like for heart disease and everything, is here also relevant. Healthy lifestyles.
But for our neurologists, can we use cannabinoid type medicine for doing this? Or cannabinomimetic drugs that we are trying to develop? I'm a chemist, as you may know.
We'll see. There are lots of endocannabinoid receptors in the neurons. We are starting to understand what are their functions and if they are good therapeutic trials for this. We know they are good therapeutic targets for other indications. We'll see if this is one of them.
We are not even sure if the problem is
You
the
need
plaques.
to use
We are not sure if the problem is the plaques, because so we are at this point. So because the trials for the anti-A-beta medications, they showed that the medication can clean the brain from the plaques, but the patient remained clinically at the same state. So we are at the point that we don't even know if the problem are the aggregation of the plaques.
There's a problem in medicine, in research, is always that you have to be really careful, and I don't need to talk to say this in this context. A correlation as high as possible never ever is a proof for etiology. So it could well be that the plaques are excellent or better changes as a diagnostic tool because they are highly correlated epiphenomenon, but not related to the cause. For example, Edgar and Odette did some years ago some research dedicated to phosphorylation of APP, the precursor protein, where beta peptides are generated from. And your data, like Eddie Koo and San Diego and others, indicated that if you have a phosphorylated APP, then the intracellular trafficking fate of this APP is different. It's transported to sites where more these beta peptides are generated. Then it looks like it's beta peptides, but the deeper level reason would be a hyperphosphorylation state. So affecting tau, which hyperphosphorylated aggregates, then the neuron can't transport all the intermediates from the nucleus to the synapse anymore because it's a microtubulus associated protein, so the synaptic transport is not effective anymore. And then the problem would not be beta peptides, but to come up with drugs flattening hyperphosphorylation. Nonetheless, beta peptides would be a nice diagnostic indicator. But now tackling beta peptides as a cure would be completely wrong. So it's, yes, we don't know this yet. And so Biogen, they claim, look, if you have an in-depth look at the data, we started not early enough, and due to some safety concerns, which were adequate, they were reluctant to use a high dosage therapy arm to many patients, especially not to those who were ApoE4 positive, because they were afraid that they would get a too high percentage of microbleeds, because this antibody leads to brain edema and microbleeds, and this especially in those patients who are apolipoprotein E4 positive. But then in the end, it was crystal clear that only the high dosage facilitates enough monoclonal to get into the brain. But now these patients were underrepresented, especially in one study, and the one which was not successful. Because one Biogen study was successful, the primary outcome was reached, the other was not. So, and the US colleagues from the FDA said, yes, that's convincing. We give you a chance to do the post-market proof. We need higher numbers to finally see is this just brain cosmetics, removing a plug, or is more behind this? And the European colleagues say, no. What you presented so far is not convincing us. We want to see clear data on clinical efficacy, not only on brain molecular cosmetics. So the European colleagues think, okay, the US will invest the money, they will pay for the antibody, we will see the data, and then conservative, we will take our decision. But it's not decided yet.
Thank you. So I think for finishing, I will give to each one of you a last word, which is your expectations in terms of this disease, in terms of this project for the future. And I will start with Luis, finishing in the end.
I think we talked a lot about the expectations, and this really opens a whole new field. I think I hope that this project will help us to provide a better diagnosis for our patients and to improve our standard of care. And I hope that it will help us to answer some questions, some research questions that I think are really interesting that we touched along our discussion, and hopefully lead us to better understand the causes, because as Professor Odette was saying, and as we already touched several times, this might be an epiphenomenon that is common to many diseases, and we have to find the trigger, and the trigger could be different in different those different diseases that we call Alzheimer's, and this will be a revolutionary tool to answer those questions.
Marianne.
Well, I have not much to add to these words. I also think that research is a part of a doctor's career, and that I am excited to be a part of this team, and with the findings that we can get from this project. And I think this gives us some motivation, an additional motivation to make our consultations, because these diseases are diseases that sometimes we get a little bit sad because we don't have much to offer to our patients. And the fact that we are making a research in order to perform a better diagnosis and to maybe offer a treatment to our patients, that it's very exciting.
Thank you. Odette.
I think I've been in Alzheimer's disease for many years. I've dedicated my research to Alzheimer's disease. And I think I can say, I think I'm witnessing a milestone.
Yeah.
Whether we at Aveiro and Centro Académico Clínico with Feira and Gaia, in collaboration with Göttingen and all our sponsors, whether we can make a difference, here's a challenge. And can we respond in the way that you're expecting? This is our immediate challenge. So in the next year, I think we have a race to get this on the market. Can we make it? I don't know. I look at the young people, the people that we are training, and I think we have the techniques. Do we have the rest? So this is our challenge for the next 2-3 years. Beyond that, diagnostics is always developing, you know, and there will be other diagnostics. This is not a diagnostics that will be there for 10 years. This is a diagnostics, I think, that will be there for 5 years.
Yes.
And then there will be a better one. And to keep up, we have to keep up. And also, I think that the fact that we have this milestone, where we may play a bigger or a smaller role, I don't know, will free up some brain power, if you like, for us to look at therapies. And we are now in a luxury situation. If someone is looking at Alzheimer's as a research area, because we have these new biomarkers, and because of the study that Jens mentioned, there are many others like it, where we know that little things happen at the synapse before we even have the aggregates. We are in a very good position to start to look at therapeutic targets. So I think it'll be very exciting. This is for the next 10 years. So this is what I envisage.
Jens?
Yeah, I will keep it short because I occupied much too much time already. Yes, I think the half-life of diagnostics is really small. If you want to be competitive, you have to be speedy. And but if you have once established the platform and the brain know-how, you can also adopt and actually participate in the race, let's say it this way. And in a scientific context, I would say I'm quite convinced that this blood biomarkers really will speed up the development of new preventive therapies, not only in AD, but we mentioned MS, to follow and to learn from the fates, the clinical fates of single patients. The neurologists did excellent combination therapies, like in oncology, really smart designs to combining certain drugs. And so if this would be combined with this readout in the bloods, you may even learn much more. What is the best combination for this single patient? So I think this blood biomarkers will significantly add to optimal therapy. But yes, you have to be, it's highly competitive. But if you have a site who is strong in technology, basic science, preclinical science, then that's excellent because you have all the know-how to compete with others. So there, a pure medical environment, medical school is not so helpful because for this research, you need all this excellence in chemistry, physics, and preclinics.
Thank you. So my wish is, as you write down in your last slide, that we can establish a national reference lab on preclinical neurological research, and that within the clinical academic center that we can go ahead with this and with other topics, and also to reach that the medical doctor that will be involved in research has reserved up to 30% of the time to devote in research, as it is established in the law, but it's difficult to reach this. And well, I will thank you for sharing with us your thoughts and with the discussion, and thank you very much.
Thank you.
Por questões particulares, a intervenção do Sr. Engenheiro Ilídio Pinho não irá ocorrer. A mesma será lida pelo Sr. Vice-Reitor Artur Silva.
Well, as it was said, there was an issue with an health issue in the family of Engenheiro Ilídio Pinho, and I will read the message from him. Jens, I will read in Portuguese because it is written in Portuguese. Then I can explain you. Primeiro, dirigia-se ao Sr. Reitor, ao Sr. Vice-Reitor, ao Sr. Diretor do DCM, ao colega Jens e a toda a audiência. E depois começava. É muito estimulante para um empresário que é simultaneamente professor honoris causa da Universidade de Aveiro, membro do seu Conselho de Fundadores e financiador da Cátedra Ilídio Pinho, encerrar esta conferência dedicada a diagnosticar o Alzheimer. Utilizo a palavra estimulante porque estimular o cérebro e estimular a sociedade são duas atividades fundamentais para a Fundação,
a que presido e para as empresas que criei. Estimular significa, enquanto verbo, causar estímulo a alguém e incentivar a realização de algo mais. Dizem os dicionários que, como verbo pronominal, em bom português, é encher-se de brio. Estou, de facto, cheio de brio pela colaboração com esta universidade, onde, além de muitas outras valências, há uma cátedra de neurociências que leva o meu nome e traz a Portugal o professor Jens, nome maior da investigação científica com vários prémios e patentes registadas, mas também compositor dessa arte universal que é a música e de quem tivemos hoje e aqui, e vamos ter, o privilégio de ouvir uma interpretação ao piano. Obrigado pela mistura de arte com ciência nesta sessão a que a Universidade de Aveiro serviu de palco, fazendo jus ao seu lema de teoria, poesis, praxis. Tivemos hoje aqui uma aula prática e várias lições de sapiência, onde como diagnosticar essa terrível doença que toda a gente conhece por Alzheimer, que provoca uma deterioração global, progressiva e irreversível de diversas funções cognitivas e que afeta a memória, a atenção, a concentração, a linguagem e o pensamento. Foi para mim particularmente estimulante aprender hoje convosco e ser estimulado a participar no vosso combate a esta doença que afeta o futuro da nossa sociedade e faz perder qualidade de vida não só a quem dela sofre, mas a todos que os rodeiam. Atrevo-me por isso a dizer que a medicina é, de entre todas as ciências, a mais humanística das atividades científicas. A Fundação Ilídio Pinho e eu próprio consideramos, por isso, que é na luta contra o sofrimento humano que devemos concentrar esforços para inverter as tendências que apontam um futuro muito problemático nesta área. Agradeço à Universidade de Aveiro e seus mentores da Cátedra Ilídio Pinho esta disponibilidade para uma cooperação que a sociedade reconhece. Daqui a uns anos, se todos formos suficientemente estimulados, poderemos recordar esta sessão como mais uma etapa nessa luta onde a memória, a atenção, a concentração e a linguagem científica que aqui foi utilizada ficarão gravadas como contributo de cada um de nós para o bem comum. Como cidadão deste nosso pequeno Portugal, sinto-me muito orgulhoso por esta universidade tão portuguesa, à qual tenho a honra de pertencer, estar a contribuir para a prevenção a nível global das doenças de Alzheimer e de Parkinson. A Universidade de Aveiro e todos que estão empenhados neste projeto ficarão para sempre realizados na luta pelo alívio do sofrimento de doenças assumidas na sua dependência subhumana. Muito obrigado. A minha saudade para todos vós, Ilídio Pinho.
Segue-se um momento musical. Ao longo desta sessão, tivemos o prazer de ouvir 2 momentos musicais interpretados pela pianista Shocher Roveyan, à qual agradecemos o seu contributo. Em nome do Sr. Vice-Reitor e Presidente da Direção do Centro Académico Clínico Egas Muniz, Professor Dr. Artur Silva, agradecemos a presença de todos e damos por encerrada esta sessão.